All right, today we begin our consideration of the cranial nerves, which we will cover, all 12 of them, plus a little bit about the sympathetic innervation of the head, which is independent of the cranial nerves in some ways. This is a different part of the course now in the sense that most of you, I think, will find appealing in that whereas the trunk is 98.5% memorization and 1.5% using your brain for solving issues, this is much more a functional anatomy part of the course. There will be problems, and you can memorize a lot of stuff. But in fact, it is a real exercise in problem solving to understand what happens when cranial nerves go wrong and what the consequences will be. So let us start here with, just want to lower the lights slightly. The first cranial nerve, the olfactory nerve. Many of you already know that's not anything that we have seen so far, even though we were looking into the cranial cavity. It's because the olfactory nerve is not a single nerve on either side. It consists of the bundles of axons which travel from receptor cells here, and this is the nasal septum. There are receptor cells up near the superior aspect of the nasal septum. There are receptor cells on the superior part of the lateral nasal walls as well. And those olfactory receptor cells send axons which gather themselves together in, I don't know, this shows maybe 10, but it's usually 15 or 20 bundles of dissectable nerves, if you have a dissecting microscope, which pierce through little holes in a portion of the ethmoid bone called the cribriform plate of the ethmoid bone. And these things are called phyla olfactoria, these 15 to 20 or so bundles of axons from these olfactory receptor cells on either side. And therefore, the olfactory nerve is, in fact, on each side, a group of 15 to 20 phyla olfactoria. Those axons within the phyla olfactoria enter the olfactory bulb, which most of you did see in dissection, and the axons terminate there by synapsing on cells of the olfactory bulb, which is considered a part of the brain. It's not a cranial nerve, it's a part of the brain. It's a nucleus of the brain, which is extended out from the inside of the brain. And from the olfactory bulb travels the secondary neuron axons back to the brain, to the inner part of the brain itself in what's called the olfactory tract. Here is the picture which those of you whose brains were taken out perfectly saw, which is the olfactory bulb sitting on the undersurface of the frontal lobe of the brain in the olfactory tract. Now, what are the sorts of things that can damage this system? Damaging of the olfactory nerve is pretty uncommon, to be honest with you. It really can occur almost only by fractures of the cribriform plate of the ethmoid bone, fractures of that bone. Yes, Ross?
Do you mean bulb or nerve?
Did I say nerve?
Yes.
That's what I meant. Damage to the nerve is hard to get. You have to fracture the cribriform plate, or, as the question was asked, maybe by you, and I can't remember, or by someone in this class. I remember the question you asked just 10 seconds ago. I mean the one that was asked when Dr. Larson gave her lecture. I don't think it was you. What is the relationship, this is based on a question on an exam, what is the relationship between a subdermal hematoma and loss of smell? And the relationship is this and this only. If you hit the back of the head violently, or the front of the head violently, and your brain sloshes back and forth, not only may that tear off cerebral veins from the superior sagittal sinus, causing a subdermal hematoma, but it takes the olfactory bulb and it sloshes back and forth and shears off these phyla olfactoria. So people who have serious blows to the front of the head or back of the head can, in fact, suffer not only a subdermal hematoma, but they may not. They can also suffer loss of smell. Now, that is generally bilateral loss of smell. It's very hard. Bilateral damage is not informative because right now I have a cold, so I don't have much smell either. Lots of people have very poor senses of smell in general. And when you're looking for something that's really diagnostic of a disease, it's much better if, for you as a diagnostician, if the signs of the damage are only on one side. And then you can really tell. So a person comes in, I guess if a person comes in and says, I hit the back of my head and now I don't smell anything, you can say to them, I know why. You can't do anything about it, like that. And so it's almost irrelevant to make that diagnosis. On the other hand, there are damages to the olfactory system that are of consequence. For example, one of the most common types of damages to the olfactory system will be a meningioma of the dura in the anterior cranial fossa. And meningiomas of the dura on the undersurface of the temporal lobe will compress the olfactory bulb. So that's not damage to the olfactory nerve. It's damage to the olfactory bulb or olfactory tract. And that can lead to unilateral loss of smell, and that's a very much more diagnostic situation where you really have to start wondering what's going on if a person has unilateral loss of smell.
Question?
Yes. Yes.
A lot of times when people get older, they tend to lose their sense of
Yes, that's true. I don't know why.
Oh.
I don't know anybody who's old, so. I don't know why, but it's very true that people lose their smell as they get older. And bilateral loss of smell is not anything that you worry about very much or anything you could do very much about. But unilateral loss, you have to start looking for the causes. And I'm going to show you some videos. These are freely available to everybody. This is the website, and it's in your, because you have the PowerPoints from you, so you know this website. How to do videos of how to conduct a neurologic examination. How to conduct a neurologic examination. It's a very thorough neurologic examination. It's something that you don't do as a family physician very often, but sometimes you do bits and pieces of this, but it's very instructive as how you conduct a thorough neurologic examination of the cranial nerves, and it has this woman who I'm madly in love with. You will too, by the end of these series of lectures, you too will be madly in love with. He will tell us how to conduct an examination of the olfactory nerve.
We'll start with the cranial nerves. The first one is the olfactory nerve, which assesses sense of smell. In order to do this, you need stimuli that are not visible to the patient and should not be noxious or irritating, as that would actually stimulate the trigeminal nerve. The patient is asked to close their eyes and occlude one nostril. I've put a scent under your nose here. Sniff it. And what did you smell?
Cinnamon.
That's correct. Okay. Close your eyes again. Occlude the opposite nostril and take a sniff. Do you recognize that?
Kitchen spices.
A kitchen spice.
Yes.
That's right. And in fact, it's cloves. But many people, just like Andrika, who clearly doesn't spend enough time in the kitchen, couldn't identify that as cloves. So as long as they can perceive the odor and give you an appropriate answer, that's sufficient.
The bottom line is you look for unilateral loss of smell. You look for unilateral loss of smell, and then you worry if you find it, that a person probably has either a tumor of the frontal lobe of the brain or a meningioma covering the frontal lobe of the brain that's compressing the olfactory bulb. Optic nerve, a much more complicated and important nerve, really. Number two, just some things about the eyeball. You are responsible for learning the names of the different parts of the eyeball, even though we don't really do. You can dissect it if you want to. You can cut one open if you want, but we really don't ask you to do that necessarily. But in this particular slide, I just want to emphasize that the inner lining of the eyeball is your retina, and that the retina has both an optic portion, shown in orange here, where all the rods and the cones and the various cells on which the rods and the cones synapse are located. And then there is, in fact, a portion of the retina which continues anteriorly from that, which is called the non-optic retina and has no light-sensing ability whatsoever, but serves as an epithelium over this thing called the ciliary body and forms the posterior layer of your iris as well. The optic nerve comes in on the medial side, so it's medial to what would be called the posterior pole of the eyeball. Here the cornea would be the anterior pole of the eyeball. Right at the posterior pole in the retina itself is a depression called the fovea centralis, because the retina is a multi-layered tissue, and only the most peripheral of the layers are light receptive. That's where the rods and the cones are, right at the periphery of the retina here. All the other cells, which are more centrally placed, where these little fringe-like things are here, these are just transmitting electrical signals from the cones or the rods. So at this one site, all those other cells, which are just for the purpose of transmitting signals, are sort of shoved off to the side. And you have exposure of cones here directly to light without the light having to pass through any other cells to get to them. And that's called the fovea centralis, and it is the region of your highest ability to perceive light and distinguish small gradations. So what you do is you always try to focus your fovea centralis, or you try to aim your eye so that the thing you're most interested in, the light rays from that hit your fovea centralis, the highest area of discriminatory ability. Here is just what it looks like inside an eye with an ophthalmoscope. You see this little, you can almost see actually a little dot there, which is the fovea. All right? There's an area around the fovea where there are still multiple layers of cells, but there are no blood vessels. And that's, again, to keep everything from anything that might interfere with the light from getting to might refract light or from getting to your fovea. So this area which surrounds the fovea, which is free of vasculature, is called the macula. And then here is the area where the optic nerve enters the eyeball, and that's where all the vessels, the arteries, which are supplying the retina, come, and all the veins which are draining the retina come. There's a sentinel retinal artery and a central retinal vein, which is passing down the middle of the optic nerve. And then they enter here at this area, which is called the optic disc. That's where the optic nerve joins the eyeball, and then we see them radiating out and going everywhere except in the region of the macula. This will be medial. I remind you that the optic nerve enters the eye medial to its posterior pole, so I can tell you which eye this is. Which eye is that? That's right. Left. Remember something? That's right. Here, half right, half left. One of them was right. It's the left. Because, as I said, this is always medial. I mentioned that you always direct your eye so that the thing you're most interested in, its rays of light, come straight through the middle of the cornea, the middle of the lens, and hit the fovea. And that's called the optic axis. This line between the middle of cornea and the fovea is called the optic axis, so you're always directing your eyes so the optic axis is pointed at the thing you're most interested in seeing. What was I going to? Oh, yes. I put a blank there to remind me I wanted to say something that's not on a slide. All right, so when you're looking out at the world, everything that you, with your eyes pointed straight forward, looking in the far distance, so your eyes are parallel, your optic axes are parallel, and pointing out to infinity. Everything that can be perceived by the eye is referred to as your visual field. And there's an upper part of your visual field, and there's a lower part of your visual field. That's above the pupil is the upper part, and below it is the lower part. Then there's a right part of your visual field. So from my nose all the way to the right is the right part of my visual field. From my nose all the way to the left is the left part of my visual field. That's for my whole body. But each eye has its own visual field through its pupil. So this is the right visual field of my right eye. That's also called the temporal field because it's near my temple. Out here, if I cover it, is the left visual field of my right eye. That's also called its nasal field of vision because it's closer to the nose. If I look at my left eye, this is its left or temporal field, and this is its right or nasal field. So each eye has its own upper and lower and right and left visual fields, as does the whole human being have that. This is a map from some ophthalmologic text of the right eye's visual field. Here's the optic axis right down the middle here, and just points out to you that the right visual field of my right eye, or my temporal field, is actually much more extensive than is the nasal field of vision. You can see things virtually out to 90 degrees from your body out to the side, but the nasal field is in the low 60s. And that's because the bridge of your nose interferes and blocks what you can see to the nasal side of your eye. And not only are there nasal and temporal fields of vision for each eye, but we refer to the retina of each eye as having a temporal portion and a nasal portion. And this is said to be for the right eye. If we're looking down onto the schematic view of the right eye, here's the bridge of the nose. You know from your dissection that there's obviously a left and a right optic nerve and that they meet at the optic chiasm. And from the optic chiasm projecting to the brain is the left and right optic tracts. But here I want to emphasize that the right half of a retina, of the right eye's retina, is called its temporal hemiretina because it's on the temple side, and the left half of a right eye's retina is called its nasal hemiretina. And similarly, the left half of the left eye's retina is its temporal, and the right half of the left eye's retina is its nasal hemiretina. These are the halves either closest to the nose or closest to the temporal region. Here is the right field of vision of the right eye. That's its temporal field of vision. Because the lens, like all camera lenses, inverts things. Oh, sorry, won't be saying that till later, I guess. Here's the left field of vision, or the nasal field of vision of the right eye. I've tried to draw these corresponding to the data I showed, where I put a 90-degree line out here indicating that your temporal field goes out 90 degrees, and this should measure about 62 degrees. If you get your protractor and measure across that, it should be about 62. The bridge of the nose interfering with the nasal field of vision of any eye. And this is the point I thought I was going to make right there. Because the lens inverts the image, the temporal field of vision is projected onto the nasal hemiretina of an eye. And the nasal field of vision is projected onto the temporal hemiretina of an eye. Here is the left or temporal field of the left eye being projected onto its left eye's nasal hemiretina. Here is the right in green and shaded as it changes across its other fields. The right field or nasal field of the left eye projected onto the temporal hemiretina. So fields are projected onto the, if you're talking about nasal and temporal, using that nomenclature, they're projected onto the opposite hemiretina. If that isn't confusing enough, and it isn't if you know anything about lenses, the axons which pass from the temporal hemiretina pass through the optic nerve, that's obvious, but they do not cross in the optic chiasm. The axons from the temporal hemiretinae of both eyes just walk past or on the lateral edge of the optic chiasm and enter the same side optic tract. So there is no crossing of axons from the temporal hemiretina. Left eye's temporal hemiretina goes in the left optic tract. Right eye's temporal hemiretina projects to the right optic tract. On the other hand, the axons from the nasal hemiretinae of both eyes cross in the chiasm. That's what creates the chiasm. Chiasm just means something crossing point. And so the nasal hemiretina of the left eye projects into the right optic tract, and the nasal hemiretina of the right eye projects into the left optic tract. And as a result, if you look at your left optic tract, which has temporal hemiretina of left eye and nasal hemiretina of right eye, it's carrying information from all the green and blue stuff, which is the right visual field of this person. And if you looked at the right optic tract, it is carrying all the information from the orange and yellow stuff, which is the left visual field of this person. So each optic tract carries the contralateral information from the contralateral visual field of an individual. Now we will see a more thorough discussion by our friend.
The next assessment is of the visual fields, and this can be done by confrontation, first each eye alone. There are three different methods I will demonstrate for the peripheral fields. One is confrontation with wiggling fingers, the other is by counting fingers in each quadrant, and the final one is with the use of a white pin. The approach is similar, using all three stimuli. You stand approximately 1 meter from the patient, or if you were both sitting, you want to be such that your eyes line up. The patient is instructed to cover one eye, and you cover the opposite eye. Andrika, please tell me when you see a finger wiggling.
Now. Now. No. No.
Excellent. We can do the same thing with finger counting, and I'm going to show you either 2 fingers or 1 finger. And you tell me how many fingers you see. Cover your right eye. Look at this eye. How many fingers?
2. 1. 1. 2. 1.
And clearly Andrika is getting all the stimuli correct. The final way is with a white pin. Again, cover your right eye. And tell me when you see this head of the white pin as white. And it'll be moving as well. Say now as soon as you see it.
Now. 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 Now.
You cheated, you looked at it. Okay, keep looking at my eye, please.
Now.
And just as in this example, sometimes you have to remind the patient to maintain fixation on your eye. We can also assess central vision with use of a red stimulus. And to assess central vision, you need a colored object. And so a red pin serves you very well. Here you're really looking at the 15 degrees or so of the vertical and central meridians. The lines, if you assume that that is central vision. Cover this eye. Look at this eye. And Andrika, I want you to tell me when you see the pin as red. Say now as soon as you see
Now.
red. How about up here? Do you see the pin? Is it red?
No.
What color is it?
It's black.
Tell me as soon as you see it as red.
Now.
Keep looking at my eye.
Now.
Keep looking at my eye.
Now.
And you can see that when assessing central vision, in fact, the visual field is much smaller than it was for the peripheral fields. Finally, using the red pin, you can assess the blind spot. And most people aren't even aware that they have one. This is done by, again, asking the patient to close one eye. And the blind spot is located about 15 degrees.
The blind spot is where your optic nerve enters the eyeball. There are no photoreceptors at that site. So anything that lands, any piece of light that lands precisely on the optic disc is invisible.
Off the vertical meridian, just usually a little bit below the horizontal. You line up your eye against the patient's eye. Andrika, I'm going to ask you to look at the red pin and tell me when its head disappears.
Okay.
Okay, sorry, you're going to look at my eye, rather. Do you see the head of the pin? Tell me when the head disappears.
Now.
Okay, so I have to move my head just a little bit, and once I've done so, the head has disappeared for me as well. Tell me when the head reappears.
Now.
Gone?
Yes.
Tell me when it reappears.
Now.
Gone?
Yes.
Tell me when it reappears.
Now.
Gone?
Yes.
Tell me when it reappears.
Now.
Okay, gone?
Yes.
And you can see that there was a spot, known as the blind spot, where Andrika was unable to see the pin. When testing the visual fields in a patient, you assume that your own visual fields are normal.
So the fact of the matter is that I've never seen a physician, neurologist, or otherwise test for the size of the blind spot. Maybe you have. I never have. The blind spot will get larger if you have what's called papilledema, which is edema or swelling of your optic disc due to increased intracranial pressure and things like that. But it's more readily seen through an ophthalmoscope than by measured that way. Yes?
If the person has like red-green color blindness with the red pin test, would you see a change in like?
Good question. The question is, if a person had red-green color blindness, and I'm guessing, would you still be able to use this test that she used for the area around the fovea for the central vision? I can only guess the answer would be yes, because apparently it looks black outside of that area. In a red-green color blindness, it's going to look some color, I guess, just not black, but some color. But I don't know whether they'd be able to identify whether it was green or red. But I think they would see it as color. That's just a deduction on my part. All right, so I want to show you what happens if you have a disease or a condition that interrupts your right optic tract. If you interrupt the right optic tract, clearly you have lost all the information from the left nasal and the right temporal hemiretina, which is all the information that's in your left visual field. And you've lost half of your visual field of your left eye. You've lost its left half. And you've lost half of the visual field of your right eye. When you lose half of the visual field of each eye, that's called a hemianopia. Half of the visual field of each eye. Because you have lost the left half of the left eye and the left half of the right eye, that is called a homonymous hemianopia. The same half. It's not the same in terms of temporal nasals terminology, but it's the same in terms of left-right terminology. So I've lost the left half of my left eye and the left half of my right eye. That is a homonymous hemianopia because it's the same half of each eye. And in this particular case, it is a left homonymous hemianopia. It's the left half, which I lost the same of both eyes. This is a total and complete interruption of the left optic tract. I've lost the right field of both eyes. So since I've lost half the visual field of each eye, that's a hemianopia. Since I've lost the same half of each eye, the right half of each eye, it's a homonymous hemianopia, and it's very clearly a right homonymous hemianopia. So an optic tract, now, you can do the deduction or you can just remember, which is what you will do, that an optic tract lesion produces a contralateral homonymous hemianopia. A right optic tract lesion produces a left homonymous hemianopia. A left optic tract lesion produces a right homonymous hemianopia. You lose the opposite visual field to the side of the tract injury. Let's see if we can figure out what this person has wrong with him. There's a guy who was asked to raise his hand every time he sees something. So, your diagnosis. Left optic tract diagnosis is the perfect and excellent diagnosis. And this is really, when you have these things, he had a complete right homonymous hemianopia. He could not see anything to the right. On his right eye, he couldn't see anything to the right of its optic axis. On his left eye, he couldn't see anything to the right of its optic axis. And it is really, it's complete. This is it. There's not, you can see absolutely nothing to the right of your right eye's optic axis. And you do see something to the right of this eye's optic axis because you're starting to get the nasal field of the right eye. Now, here's a different kind of hemianopia. This is a hemianopia where you have a white bar right here, destroying the optic chiasm. All right? And when you destroy the optic chiasm, you obviously destroy all of the projections from the nasal hemiretiny of both eyes. And that means you are destroying the temporal fields of vision. You're not destroying, you're losing the temporal fields of both eyes. Now, you're losing half the visual field of each eye. So it's a hemianopia. But because it is not in the right-left nomenclature, is not the same. You're losing the right field of the right eye and the left field of the left eye. This is called a heteronymous hemianopia. But you usually don't use it is a heteronymous hemianopia because it's the right field of one eye and the left field of the other. But in fact, this one is almost always called bitemporal hemianopia, which is a kind of heteronymous hemianopia. A person with a bitemporal hemianopia, you can see what their visual field looks like. One of your colleagues said to me, this is universally called tunnel vision, and in fact, it is universally called tunnel vision, but it is not tunnel vision as you and I would understand looking down a tunnel. You've got, if you just put your arms out at 62 degrees like that from each side, that's what your visual field looks like. So if I'm standing here and I put my arms out 62 degrees from each side, pretty much I can't tell that I've lost any vision out there at all. People who have this really don't generally perceive themselves as losing very much of their field of vision. What they don't, and it comes on insidiously, what they don't often realize is that they've lost all of their near peripheral vision. So when you lose your near peripheral vision, I could stand here. At this point, I might not be able to see you two. I mean, I might miss you two. But I'd see everybody in the back row quite easily, and most of the people from about the third row on quite easily. But I would not see anything close to me and out to the side, so I'd be walking around here, and I'd be bumping into objects that were close and out to my side. If I went to park my car, I'd back in, I'd scrape the car. Well, they don't park cars anymore like that. Maybe they do in New York still, in the city. But out where we live here, there's no parking on the streets. So, but people like this talk about bumping into objects a lot, damaging their car, hitting their cars against other cars a lot, because they lose their near peripheral vision. But they don't talk about, gee, it's like I'm looking down a tunnel, as you can see. Now, what is sort of tunnel-like about this is the overlap of the visual fields is tunnel-like. You have only this narrow area of overlap, and if you go to actually look and focus on something right here, you only have this little triangle where you have overlap of your visual fields. It's only within that triangle that you have very good depth perception, because you need overlap of visual fields to have the best kind of depth perception. So people who have bitemporal hemianopia also have problems with what's called stereopsis, that is telling how far things are relative to one another. So they also have accents because of that. They can't gauge distances of objects relative to one another except in this narrow area where you have overlap of the visual field. Now, how might you get a bitemporal hemianopia? How might you get a condition in which your optic chiasm is damaged? And I tell you this because I haven't looked at national board exams in a few years. But prior to, let's say, 3 years ago, every single step one had this question, every single one. And it had to do with what can happen to cause you to endanger your optic chiasm. Now, the optic chiasm sits where that question mark is. I obviously meant to ask somebody a question. What sits there? What sits there, Katie? You. Hey.
The pituitary gland.
No, where this thing right here, here the optic canal.
What is it called?
No. What sits right in this mild depression in front of where the pituitary gland sits?
You have optic tracts when you go pituitary.
Optic chiasm.
Oh,
You weren't listening to me because I gave you the answer before. All right? That's where the optic chiasm sits, in that little depression in front of what sits there, which is the pituitary gland. So people who have pituitary tumors in addition to having, well, there's a whole variety of kinds of pituitary tumors you can have. And you'll read about, well, no, you won't read about it at all. But in fact, there are variety, I mean, because there's all sorts of, there's some tumors, they're not usually malignant tumors. These are adenomas or benign tumors that produce too much of one or the other type of pituitary hormone. Too much growth hormone produces acromegaly. Too much ACTH produces Cushing's disease. And then there are other varieties too. So people do get these benign tumors of the pituitary, which have lots of symptoms, but when they get big enough, they can do this. Here is a normal pituitary fossa, and here is one of a pituitary that has a large adenoma. It is called it causes erosion of all the bone and will press on the optic chiasm. And essentially the only way I know of, but there may be some I don't know, but the only way I know of getting a bitemporal hemianopia is by a pituitary tumor pressing on the optic chiasm. But since pituitary tumors are not that uncommon, it's probably not such an uncommon, well, it's not like 1 out of every 3 people, but it's not unheard of because pituitary tumors are not uncommon. So that should be on step 1 of the board. The relationship between bitemporal hemianopia, pressure on the optic chiasm, and a pituitary tumor